Fine.
Now, is everybody audible?
Yeah, I think it's perfect.
Okay. So, right from our post-graduation days, the moment we enter into radiology, we have always been bombarded saying that MR is way more superior to CT. MR gives much more information. A lot of hype is given to MR. In the bargain, we tend to overlook CT. But there are certain situations where you should not do this. You should look back, take a little CT cut, and then this CT cut helps us to eases our life so much that we can arrive at a conclusive diagnosis just by looking at the CT images. Okay. Sometimes we make erroneous diagnosis just because we don't look at the CT. So I just want to illustrate a few things where this is completely out of the books. Okay, this is just what I have learned over a period of years in my clinical practice, where you should go back and ask the patient to get a little CT done. So everybody may not have the same opinion, but what I feel is this should be inculcated in day-to-day practice so that we don't miss some important clues on CT that will help us in making a definitive diagnosis. So many a times, a lot of clinicians just call up and ask, like, there is so and so patient, what to do, whether a CT or an MRI. This is a scenario where clinicians really call and ask. But off lately, what is happening is a lot of people have started referring patients. It's not just clinicians, okay? It's not neurologists or not physicians who are referring patients. The referral has started gradually shifting to general practitioners and going lower down. It goes to registered or unregistered regional medical practitioners, RMPs, and the worst is the neighbor also advises a CT MRI now of lately. This happens, okay? You have a headache, he'll tell you, oh no, go and get an MRI done. And this is very common in clinical practice day to day. So with so many people, half knowledge people advising for investigations, now the onus or the responsibility lies on us to make the decision wise enough to do the appropriate investigation and give the best possible diagnosis. So this we have learned CT versus MR, excellent bony details on CT. Air, wherever you want to appreciate air, is best appreciated on CT. For example, you want to see pneumothorax, you want to see pneumoperitoneum, you want to see pneumocephalus, CT scores better over MR. It's very quick and widely available. So there is a bad patient, irritable patient, don't bother doing an MR, quickly do a CT, gives adequate information. CT machine is far way easier to handle compared to MRI. I assume there are a few young people, entrepreneurs who are listening to this talk. Trust me, having a CT is much easier than having an MR. Interpretation of CT is much simpler compared to MR. On the contrary, MR has got excellent soft tissue resolution. Okay, you'll get better tissue characterization with MR. There is lack of radiation. It has got wider applications in diagnostic imaging. All said and done, if you are planning a diagnostic center, never ever attempt doing it with an ultrasound and a CT. If you are going into cross section, then it is always better to have both CT and MR in the same premise. That helps a lot. It is both financially viable. It helps you in making definitive diagnosis. It boosts your confidence in diagnosing the disease per se. Okay, so you give a holistic approach to the patient's diagnosis rather than restricting yourself to one particular imaging modality. So what is the missing link? Okay, why CT and MR becomes so difficult to choose? As we are also not adequately educated, what to choose sometimes is a difficult call. Clinicians are even more less educated about the advantages of each of these modalities. Okay, so in a particular clinical scenario, what best modality would maximum help us to arrive at a definitive diagnosis is a difficult call. Clinicians may not know it. Okay, and at the same time, it has to be cost effective as well. Radiologists should first understand this themselves and then try and educating clinicians around to help order appropriate investigations. Okay. On that background, let us start looking at a few cases. Okay. I'm trying this in a reverse way where an MRI has been done, the MRI has been ordered, MRI has been done, and retrospectively we have gone and done a CT to make a definitive diagnosis. Okay. Because after having done a CT, doing an MR is a very routine thing. That is because MR gives definitely much more information compared to a CT, but sometimes the reverse way also helps. First clinical situation, if there are any takers for the image interpretation, that would be appreciable. So this is a 40-year female with headache under evaluation. So for people like me who are practicing in tier 2, tier 3 cities, there is there's always a conflict of whether to do a CT or do a limited MR. Now, of late, they have started doing limited MR. They don't order for a full investigation, also half-hearted, they order for a limited MR. And you cannot deny these investigations because of the economic constraints, patients not able to pay for the entire study. We sometimes have to resort to doing a limited study, wherein we acquire a very few set of sequences to give maximum amount of information that is possible. So on one such situation, female with a headache was sent for a limited MR brain. I'm scrolling through a few images, representative images. We are looking at flare axial, T2 axial, then Graham's gradient axial. So here's a young 40-year female. We are looking at a limited MRI brain. So we are looking at a T2 hypointense area in the interhemispheric fissure. She is presented with headache, and that is showing blooming on gradient images. So we are looking at T2 hypointense collection in the anterior. This was reported elsewhere as T2 hypointense collection in the anterior interhemispheric fissure along the pericallosal regions. It showed blooming on gradient sequences. Okay, so a suspected DACA aneurysmal bleed was given. Okay, somebody called it inferior sagittal sinus thrombosis. Yes, can be considered, or some hemorrhagic collection because it was blooming on the gradient, looking dark on T2 varied images. Okay, and the patient has presented with headache. So the moment something like this is put on the paper, it creates a lot of panic in the patient's mind, the treating physician. Okay, and then everybody starts investigating further. Okay, so this patient was sent for a CT angio. They said, considering the aneurysmal bleed in the intrahemispheric fissure, they said, let us get a CT angio done. And when it came to us, we just did a plain CT, and this was what we saw. I think it's quite obvious here. We see a fat density, tubular nodular area along the pericallosal or the callososeptal margin. You can appreciate the density of this area is minus 80, which confers fat. Okay. So going back, we'll go back. Let us see one more case. So there is fat density lesion along the pericallosal regions. There is no hemorrhage. There are no calcifications. Okay. We'll come back to this case after this case. So there is one more elderly male. He is a 74-year male with acute onset headache, giddiness, severe irritability. Okay. So in such patients, what would be the investigation of choice? Okay. As I said, somebody asked, what about T1 varied images? Since it was a limited MRI that was being done. So what is limited MR in routine practice? It is flare, gradient, diffusion varied images. That is usually limited for stroke imaging, but uh, it is being wrongly used for a lot of other indications of lately. And as radiologists, we do not have a control about what investigation we can do for the patient, because the clinician will say only you do this much and the patient is not affordable. Okay. So in those situations, we end up with such tricky situations. Okay. So here's a 74-year elderly male, acute onset headache, giddiness, he's irritable. despite being irritable, sometimes we get such patients and we think, let us do a CT. And once we do CT, what happens? All that we see is in an elderly male, we see a lot of atrophy, a lot of chronic ischemic background, and then we really don't get anything. And then we end up reporting that we are not able to see anything. But suppose an MR is being done in these patients, sometimes we get some findings, as in we get multiple embolic infarcts, okay, which are difficult to diagnose on a CT. So despite being irritable, we thought, okay, let us go ahead and try and do a little MR brain for this patient. This is T2 axial. We see something looking heterogeneous, hypointense, and then mixed hyperintense in the retrocerebellar vermian area. It showed a lot of blooming. Okay, on the gradient images, there was a lot of blooming. It looked intense on even. So again, sometimes in busy OPDs, what happens is whenever there is an irritable patient and you see something like this on the gradient, okay, and there is a bleed, there is a hemorrhage in the cerebellar region. Okay, so heterogeneous T2 hypointense lobulated area in the retrocerebellar region, significant blooming on gradient images, suspected intracranial bleed. Okay. Yes, the other differentials here, one could think of calcified meningioma in the retrocerebellar region, falcine meningioma. Okay, but patient is irritable. We are not able to find any other cause for his irritability. Okay, patient is an elderly, acute onset headache. How do you explain with all the diagnoses that you people have been making, meningioma or a dermoid cyst? Can we pin down his irritability and headache to something? Yes. Is somebody? You know, good. So let us look at a quick CT was being also done simultaneously. What is CT showing? Somebody call it a cavernoma with bleed. Okay. What is CT showing here? CT is showing a lot of fat density. You can appreciate the 6. Okay. So what are these areas? So basically, there are a lot of fat globules that are seen in the ambient cisterns, in the anterior aspect of the frontal horn of the left lateral ventricle. Okay, we can appreciate fat density globules everywhere in the CSF spaces. Okay, extensive fat density lesion in the retrocerebellar region, presence of few fat density nodules in the ambient cistern and in the frontal horn of the left lateral ventricle. Yes, rightly said. This is a ruptured dermoid cyst with chemical meningitis. After having looked at these two cases, so the first one was a pericallosal tubulonodular lipoma. The second one was a ruptured retrocerebellar dermoid. Now the question is, why did the dilemma come in the first place? Why did fat bloom on? Why did fat bloom on the gradient images? Yes, chemical shift artifact. So if somebody is not aware of this entity, you should be very clear about intracranial lipomas or fat containing lesions can bloom on the gradient images. You should not mistake that blooming for either calcification or bleed. Okay, it is surely chemical shift artifacts, artifactual signal loss on the gradient images because of the adjacent fat fluid interface. Okay, the fat fluid interface causes chemical shift artifact causing significant blooming in fat containing lesions, especially intracranial fat containing lesions. The other one could be, yes, microscopic fat or macroscopic calcification that can be appreciated on the CT as well. So these are two causes for blooming in intracranial fat containing lesions on MRI brain. Okay. So whenever you are in doubt, rather than putting it on the paper as a bleed or a calcified lesion, okay, if it is always better to take a little CT cut. Additional CT cut boosts your confidence. You can definitely put it on the paper confidently that it is either a intracranial lipoma or a dermoid cyst. There is one nice article on this that says susceptibility or a chemical shift artifacts in intracranial lipomas, which can mimic hemorrhage. Okay, this case series with around 6 to 7 cases put together on the Journal of Neurosciences. Let's go to the next case. This is a 5-month-old child with microcrania and global delay had seizures. Okay, so any child with delay, first investigation is always going to be MRI brain, and especially when there is seizures. Okay, we are going to look for all the. Let us try and interpret MR. This is a pediatric brain, a 5-month-old child. Okay, we are seeing T2 axial images. So what are we seeing? Diffusion weighted images of this child did not show any restriction. Okay, so I have selected representative T2 axial images. So as I said, this is a 5-month-old child. On the T2 weighted images, white matter can still look white because of the lack of myelination. Okay, but there is a difference between unmyelinated white matter fiber tracts and areas of abnormal T2 hyperintensity. If we can appreciate these areas, they are abnormally hyperintense. So a child with microcrania, global delay, seizures, and white matter signal abnormalities. Okay, there is a huge gamut of differential diagnosis. Okay, there is demyelination, dysmyelination, okay, leukodystrophies. With these available images, can we think of a diagnosis? Difficult, right? So what we did is we did this. And this. So the moment I showed CT, all your differentials started pointing towards one particular thing. Okay, so your differentials started pointing towards a congenital neuroinfection. So what I'm trying to show on this particular image, congenital cataracts. Okay, we can look abnormally hyperdense ocular lens bilaterally. Okay, so we are looking at multiple randomly distributed tiny calcific specks that are scattered throughout the cerebral parenchyma, and in the same areas we could appreciate a lot of white matter signal abnormality on T2 varied images. Additional finding that you might encounter is cysts in the anterior temporal poles. That would be cysts, subcortical cysts in the anterior temporal lobes with bilateral congenital cataract, multiple calcific specks in the cerebral parenchyma. So they are looking at congenital CMV, cytomegalovirus infection. So whenever you feel a little lost by looking at such images, okay, it is always imperative that you go and take a little additional CT images, which might help you to clinch the diagnosis. Okay, rather than giving a vague set of differentials, calling them leucod early onset leukodystrophy, possibility of dysmyelination needs consideration. Rather than putting something like that on the paper, try to narrow down your differential. Yes, WI with phase, yes, SWI will show some specks of blooming in both the white matter, but in children, especially in the infantile, this one, the medullary veins are very prominent, so it might be difficult to differentiate between the calcific specks and the vessels or the prominent intramedullary vessels, venous channels in SWI images. So the constellation of findings: microcrania, cerebral atrophy, white matter signal abnormality, extensive randomly distributed parenchymal calcifications, and bilateral cataracts. Now tell me, how many pediatricians would be well versed with looking at pediatric eyes, and then see, many a times these things go unnoticed. Investigations are being sent without a full battery of clinical picture. So we are not given the complete clinical background. Sometimes they might misinforming, or they might miss putting it on paper. We might miss seeing it. Okay. So on MR it is difficult, but CT definitely can pick up this better. Next one. There's a 10-month-old child with, again, micropenia, spastic diplegia, and a global delay. This is a very common clinical triad that can be seen. Okay, children coming with delay, spastic diplegias, microcrania, and the most common diagnosis is, with this clinical background, congenital insult. Okay, so CP, cerebral palsy, PVL. So let us scroll through the T2-weighted axial images. Am I being too fast? Ankita? Okay. Thanks. So we look at T2-weighted images. Let us look at all the set of images before we try making a diagnosis. So these are T2 axial images of a 10-month-old child. Okay. So yes, we are definitely appreciating a bit of volume loss. We saw some abnormal T2 hyperintensities in bilateral frontal periventricular white matter. So here is our gradient sequence. Yes, there is hydrocephalus, there is some amount of volume loss. There is cerebral atrophy. So Going back to the clinical scenario, okay, it was spastic diplegia, there is spasticity, there is delay, and then microcrania. Okay. With this clinical set and this set of findings, how many of you would be able to clinch a diagnosis? It is not PVL for sure, because what is the most common site for perinatal insult associated signal abnormality? It is most often peritrigonal. Posterior gradient is most often involved. The peri-Rolandic areas are involved. Or if you have the deep gray matter type of involvement, you could appreciate it in the basal ganglia or the thalami. So we are looking at the deep gray nuclei look absolutely normal. The peri-Rolandic area did not show any significant volume loss. So PVL is out of question. And we could appreciate some specks of blooming, which cannot be ignored. So how many of you would confidently be able to differentiate these specks of blooming from vascular or the internal medullary veins from calcifications? It would be a difficult call. What are you seeing here? So whenever you see, especially bilaterally symmetrical calcifications in the basal ganglia, sorry, don't look at the image in the background. That is not a part of this. Okay, that is not a part. So only look at the CT brain images that I'm showing. Don't look at the background images. So whenever you're seeing multiple calcifications, especially in the deep white matter, okay, and then bilaterally symmetrical, predominantly involving the basal ganglia, okay, and the thalami, with a lot of atrophy, okay, cerebral atrophy, frontal predominance, abnormal T2, white matter hyperintensities. Now this constellation of findings you want to narrow down. How would mineralizing microangiopathy present? And what is the usual clinical presentation for mineralizing microangiopathy? No, please do not look at the background images. Scoliosis, vertebral, that is all not a part of this case. Okay, that's just a background. Ignore that. Sorry for that. Okay, there's somebody who has come up with the answer. What is interferonopathy? So microcrania, cerebral atrophy, white matter signal abnormality with frontal predominance, bilaterally symmetrical calcifications in basal ganglia and deep white matter. Okay. So when you see such constellation of findings, the diagnosis is Aicardi-Gouttier syndrome. Okay. Aicardi-Gouttier syndrome is a rare autosomal recessive disorder where there is deficiency of the enzyme that breaks down the nucleotides. Okay, that will lead to increase in the CSF interferon levels. CSF interferon will in turn cause white matter destruction that will leave microcalcifications or calcifications in both the basal ganglia and the deep white matter. Lot of atrophy. This was a genetically proven Aicardi-Gouttier syndrome. Okay, so if you can at least raise a concern about Aicardi-Gouttiers, okay, and then it can be genetically confirmed that it is the same syndrome. So the gist of these cases was in especially difficult pediatric cases, you see white matter signal abnormalities. Okay, you see some specks of blooming on gradient images. You're not able to conclude go ahead, do a little CT. Definitely that will help in clinching the diagnosis. The next one is a 1-year-old child with left-sided 1-year-old child with left-sided weakness, 7 days following history of a trivial trauma. Okay, this is a very typical clinical presentation in most of these cases. Sorry, these are borrowed images. I didn't have a case of my own. What do we see here? Diffusion, ADC, and T2 varied images. We see a focal area of restricted diffusion in the in the left thalamocapsular region. It's a simple infarct. It's a small infarct. Okay. So whenever you see pediatric strokes, whenever you see pediatric strokes, if you just leave them at this point, calling that it is just a stroke, the investigation for pediatric stroke involves a whole battery of investigations. Okay, it could range in anything from, as you're pointing out, vasculitis. It could be sickle cell, so many things, hypercoagulable states. Okay, so the battery of investigations is very large if you just leave it at this point. Okay, but if you take a bit of CT and appreciate these, what are these? These are tiny linear calcifications that can be appreciated along the perforating vessels of the bilateral basal ganglia. So if you see these tiny calcifications along the vessels, and if you see strokes in pediatric patients, especially following the trivial trauma, okay, this history is very typical. They come with a history of trivial trauma, followed by which they have strokes, and then you do a little CT, you find that there are tiny calcifications. Okay, so this is a classic case of mineralizing angiopathy with pediatric stroke. Focal areas of restricted diffusion in the left thalamocapsular region with low ADC values. Acute stroke, CT image is showing linear calcifications along the perforating vessels. Pediatric stroke due to mineralizing microangiopathy. So what is the take-home message after looking at all these cases? In difficult cases, a judicious use of CT will act as a useful adjunct to MR in making a definitive and confident diagnosis of complex cases. Okay. For this, the presence of mind of the radiologist is very important. You have to be present in that particular case. Okay. You have to be looking at MR. You have to ask the technician to take a CT for that particular case. Usually it is not an order. You have to take the initiative, okay, see the case during the scan and then decide whether to take CT or not. Okay, the same thing can be extended to wide clinical applications. So your presence of mind matters a lot whenever you are doing these cases. Okay, for example, there's a case of chronic pancreatitis. You see a lot of pancreatic parenchymal atrophy with dilatation of the pancreatic duct, but the MR may not be able to appreciate the extent of pancreatic parenchymal calcifications. A little CT will always help in confidently putting it as chronic atrophic calcific pancreatitis. Similarly, for documenting fat in cases of AML, ovarian dermoid cysts, okay, huge cysts, say around 20 centimeter cyst, a very tiny speck of fat that can be appreciated somewhere in some corner of the cyst. Very difficult to see it on MR sometimes. Okay, you may not appreciate it. You might just misdiagnose the case for a large complex ovarian cyst. Okay, and then in young patients, it leads to a lot of panic. Okay, if you can appreciate that fat and put it confidently as a mature dermoid or a mature teratoma, it eases the life of the surgeon. Okay, so for calcification in bone tumors, especially if you're looking at osseous matrix in tumors, you go ahead and take a little CT cut. So there are n number of such clinical situations where you interpret MR, you look at MR, and then you go back, take a little CT, interpret MR in the background of CT, additional information from the CT, and you can clinch a definitive diagnosis. I think.
Yeah, I think perfect. Will you have a look at the Q&As?
Yeah, sure, sure, ma'am. I would love to.
If there are few